So I'm Chase Silvers. Nice to meet you guys. Thanks for coming today. I'm an emergency physician. I just got out of school about a year and a half ago, trained in Ohio, but I'm originally from here and I graduated in 2010. Me and my wife both graduated from here and decided to move back home. That's where we're always wanting to come back. I don't know if you remember Brianna Gray, but she was a while back. She graduated with me in 10. But yeah, so I work in the ER. It's not kind of like Grey's Anatomy or any of those shows, if you've ever watched those. It's not like I just traverse over to the OR or do the primary clinic. You kind of do one field whenever you go into medicine. So I work in the emergency department primarily. The good thing with my job is I can kind of translocate. I can go any part of the country as long as I have a state license and I get credentialed at each of the individual hospitals I want to go to. So I can work in a metropolitan place in downtown St. Louis, or I can go to a critical access hospital that has 5 beds and sees two patients a day in Idaho if I wanted. So there's a lot of job flexibility and availability. So that's kind of what I do. I've been back about a year and a half. I'll kind of talk about my training route, which in the grand scheme of things is about 12 years post high school. So that's definitely a consideration. You got to really want to know what you want to do when you go into this. And I had a general idea what I wanted to do before I went into medical school and all of that, but we'll talk a little bit more about the thought process behind that. Let me see if I can get this keyboard to function the way I want. So I grew up in this area out by Egypt Mills. I was fortunate. My grandfather, he had retired right at the age that I was born, but I grew up around him, and he would have his neighbors, his close buddies come over for like physicals. He was a family medicine doctor, but he was kind of like the old school doc that would see anything, treat anything, and would deliver babies, sometimes do like appendectomies, open where they do the incision in the operating room. So he was kind of a jack of all trades and would do different procedures that a lot of times you don't see happen nowadays without a certain specialist or a certain person that had a specific training. So this is kind of what I always wanted to be growing up, and part of me was trying to figure out how do I get to be somebody like that in this day and age with technology and healthcare, a totally different thing. So I don't know if you guys ever watched this show. Oh no, this is a TV show. This is like an old this is an old school TV show. But anybody ever watch this show or know what I'm talking about? Yeah, House. I kind of got like the itch for medicine as well watching this, because this guy is just very stoic, dry sense of humor, off the cuff, but dealing with really medically complex things and using his noggin to try to figure out really complex disease processes while treating and trying to diagnose at the same time. That's one of the weird things in medicine, is sometimes you have to start the treatment before you confirm a diagnosis, or you have to treat different things until you hone down what it is, because time can be of the essence a lot of times in medicine. So these two kind of factors combined were kind of what drove me to go into medicine. And I'm also a busybody. I like using my hands. I like moving around. I like having flexibility with what I do. I'm not really a person that sits at an office desk all day. That's just not my personality. So anything that's moving, anything where I can use my hands is something I wanted to do in medicine. So my job in emergency medicine, if I could sum it up to 3 words, is anyone, anything, anytime. So literally in an emergency department, it's never closed. You're open 24/7. We're accepting anybody of any walk of life, race, age, gender, whatever, anytime. So on my day-to-day, as an ER doc, I work shifts. So I work, it doesn't sound like a lot, but anywhere from 14 to 18 shifts a month. So on your shorter months, that can be over half the month. And I work any and all days. I don't have a Monday through Friday job. I tend to work more day shifts and not as many overnight shifts, so that's nice. So I'm not having to flip-flop day and night. But I may work 3 days on, 2 days off, 1 day on, 3 days off, and so forth. It's all depending on need and what coverage we have. So the group that I have, there's about 7 to 8 of us total, and we utilize some traveling docs right now, but we're getting a few other ones. So that means we have about 5 shifts a day that have to be covered in the ER, meaning that you don't have a lot of pickings to be able to fill in a hole if there is one. So sometimes we got to work with amongst each other on schedule in the emergency department versus, yeah. It depends. So most of my shifts are either 10, 11, or 12. So all shifts in the ER are already kind of pre-templated. So there's a 6 a.m. shift that goes to 4 p.m. There's a 9 a.m. shift that goes to 9 p.m., a 12 p.m. shift that goes to 11 p.m., and then an evening shift, and then an overnight. So there's ones that kind of cover different parts of the day because we anticipate in the ER there's certain times of the day where we'll get big influxes of people, and so we need extra support. Versus overnight at 3 a.m., you're unlikely to have a bunch of people rushing the gates trying to, seek care. So we try to optimize how many docs or nurse practitioners are in the department as well as nurses based on the needs that we expect. But it can still be off the wall. Kind of like anyone, anything, anytime, that can literally mean anything. So I may have nothing going on at 3 a.m. in the morning, and I may have a whole busload of grannies going to a convention at SEMO that decide to get in a major car pileup, 3 of which are unconscious, 2 of which have broken legs, 1 of which is freaking out that has nothing wrong with them, and you have to be able to triage what's going on. And my job in the ER is to see who is sick and who is not sick. And I have to kind of make a doorway impression whenever I see somebody. Do I truly think this patient's sick? Do they take first priority, or do they take a second and I have to move on to the person that's the next sickness? So have you guys ever had to sit in a waiting room in an ER before? Sucks, doesn't it? And I can tell you whenever I start my job or any one of my colleagues is working each day, we're moving from the time that we get there until the time we sleep. There is not any downtime. That's what I like about my job. I got something going on at all times. So when you see a whole lobby full of ER people, it means that whole inside of the ER is full of people or people that are waiting to get up into the hospital. So I wanted to go through a couple different scenarios of kind of what I do for work. So anybody know what's going on here? That's fair. This patient's being intubated. So this is called a laryngoscope, and this is called an endotracheal tube. So this is somebody, for some reason or another, that is not protecting their airway, and they're not breathing for themselves. So this is somebody that's requiring an advanced airway to breathe for them. So when you hear of somebody being on the ventilator, that's somebody that has a plastic tube going through their vocal cords, and through a machine or through a bag valve mask is having oxygen provided to their lungs to help them breathe. So we see a lot of people through trauma. If they have facial injuries, if they have multiple injuries to their body to where they're concussed, they're knocked out, that they're not able to breathe for themselves. So we have to breathe for them. You have somebody that's in heart failure or a COPD flare-up that can't breathe for themselves and their body's tuckered out. We have to breathe for them. This is a skin abscess. So going from intubating somebody in one room to the next room that's had a boil on their leg for a couple of days that needs numbed, popped, and some antibiotics. So that's room 2. And when you're done with that one, you get their paperwork ready to go, and you have this person that just fell off their bicycle and has a big laceration to their leg. So that's another thing. Procedure-wise, you get to place somebody on the ventilator and deal with some of the mechanics that are involved with that and the sedation. You have to know how to do an incision and drainage of an abscess and how to appropriately treat that and appropriately get follow-up. And you have somebody with a traumatic injury here that could have damage to their quadriceps muscle or their tendon, or a broken femur that you have to deal with the laceration, as well as speaking with an orthopedist, which is a bone doc. So this is a CAT scan. Anybody know what we may be looking at on here? Yeah, the brain. So you have brain tissue here. All the white is usually something hyperdense. So usually white is usually bone or something calcium, but it can also be fresh blood. So on this brain, imagine that we're taking somebody's head and slicing it like this and then looking up. This would be the right hemisphere. This would be the left hemisphere. So this is somebody that's having a massive brain bleed that we call an intraparenchymal hematoma. This is usually somebody that's had poorly controlled high blood pressure over years and years and years, and some people may be on blood thinners for something. Once over years and years, those little blood vessels get so overpressurized, some of them can pop. And usually once you have bleeding this amount, this is something that's usually a devastating outcome where the patient's unlikely to survive and they're unlikely to be breathing for themselves, which requires me to have to breathe for them. And then moving on to the next room, you have somebody that was at their house and comes in with abdominal pain and that they may have slipped on something. Anybody have any idea what we're seeing on this x-ray? Yeah. How did that get there? So you have that little dynamic where people that may have slipped on something may need to have an object taken out of a body orifice. And that requires a certain skill set. Imagine if it's a light bulb that's a place that it shouldn't be. That's a whole other dynamic. What happens with the light bulb when it breaks inside somebody's cavity? So that's room 5. So this is Trauma Bay 1. You get EMS call. I was just speaking with a girl that was working for Gordonville Fire. So this would be somebody that would be bringing somebody in, likely a cardiac arrest that just came in from their home, not breathing, pulseless, just got shocked. This is something that's newer within the past 5 to 10 years. This is called a Lucas device. It's an automated chest compression delivery system. So I don't know if anybody has ever worked in an ER or been in like an EMS kind of environment where you've seen somebody do compressions. That's really hard work. You do it for 2 minutes, you're pretty tuckered out. This device takes over for that. My job here in the ER is to be the guy standing right here or right here and controlling the room. We usually have an EMT that brought the patient. We may have a couple of them. We have a nurse. We have an RT, which is a respiratory therapist that helps with managing the ventilator, managing the airway after I've placed it. And then we usually have several unit techs, people that are helping to place an IV or get materials, sometimes do chest compressions. So my job is to do some of the procedures, but also to be the team leader and to control the environment and kind of guide where the care's going. So if you've ever been in an environment like this, it's a very stressful environment, but it doesn't always have to be stressful if you got a good team working with you. And that's what I love about this job. It's a team-based job. Everyone has their role and everyone has a duty to the patients that we see. Another hard part of this job is dealing, in my line of work, is going from this and moving on to the next room and dealing with somebody that I may be delivering a diagnosis of cancer that was unexpected. I do a CAT scan for abdominal pain and I see a large mass in somebody's abdomen that looks like it's a metastatic or a cancer that's spreading that looks like it could be something that could ultimately kill them that the patient may not survive for. And switching my brain from something that's a very serious and focused environment to something that's more empathetic and something that you have to sit down for and deliver bad news. So there's a lot of mood swings with my line of work, but that's what I like what I'm doing, because you meet people at the most pure time, the most sincere time when people are needing help. And that's, I think, something that can't be taken for granted. And I think that's what I love about my work so much. And another big thing, it keeps you humble because you don't know everything about everybody. You see social media, you see people that seem like everything's perfect, when that's really not the case. You get to see what life is truly like. So a lot of times my job is providing somebody with a sandwich and a soda. Somebody that's homeless, doesn't have anywhere to go. We have a lot of those in this community, whether you've seen it or not. There's a lot of people that don't have homes or on the border of losing their home. There's a lot of people that I know that are living as roommates that don't have anywhere to go. They can't afford rent. They can hardly afford food, let alone medical care. And so they use our emergency department as a safety net. We're a safety net for a lot of people. When you can't get a hold of your doctor, you can't get into the clinic, you can't get this, this CAT scan, you can't get this procedure done. A lot of times we're the last ditch effort because we're always open, we're always available, and sometimes just a place to sleep for a little bit. If I'm, sitting down working and I have an empty emergency department at 2 a.m. and I have a a man that's homeless that's coming in with what we call chilblains. So when it's cold outside and you're walking with wet feet and sub 32 degree temps, your feet get really cold, your blood vessels get really constricted, and it's very painful. And you can end up with things called trench foot, which is kind of like an infection of your feet. And so these people walk out in the cold with nothing more and don't have running water or warm heat. Sometimes it's kind of nice just to give them a little break in their chaos of life, to let them hang out. And so it's crazy how you can go through the whole spectrum of room to room to room, different life circumstances, and just short encounters really have maybe an impact on somebody's life. One thing I liked about emergency medicine is a lot of technology. So you guys ever seen one of these devices? Yeah, it's one of those glucometers, one of those that you can, they have different brands, but it's one that syncs with your phone so you know what your active blood glucose readings are. That wasn't there when I first started medical school. It doesn't sound like that crazy of invention, but that has a significant change on compliance of patients checking their sugars. If you can just keep it on your skin and have an app on your phone that you can get your active readings, that changes crazy amounts of how good your sugars are controlled. And I get to see this stuff every single day, whereas if I'm in a different specialty, I may not be exposed to some of these new treatments or advances. Another thing, too, is the average American is on 5 prescription medications in this country. And so I have to be very knowledgeable about what the side effects of a lot of medicines are, or having a 90-year-old patient that comes in dizzy and weak and fell and hit their head while on a blood thinner. I have to consider, why did grandma fall? Why did she get weak? Why did she get dizzy? Is it something about a medicine that she's on? So knowing pharmacology is really important in this line of work. I guess I wanted to ask, what does everyone's interests kind of are? Who's wanting to do nursing, potentially? Awesome. Have you guys shadowed or done anything in that regard yet? You don't have to. I mean, it's something that just some people have done at some point. What else? Like PA, nurse practitioner, PA? Awesome, man. Heck yeah. What about like PT, OT? What's everyone thinking? Awesome. What about everybody else that has an answer? Are you considering potential medical routes, or what are y'all thinking? Just kind of, yeah, that's fine. You got plenty of time. Cardio? Awesome, man. Cool. So this is another fun thing about my job, is I get to prescribe medicines, but I also have to know about a lot of different medicines and new ones that are coming out. Oncology, which is cancer medicine, as well as cardiology, are 2 of the fastest growing fields in this country for medications that are being produced to treat ailments, as well as research. So there's a lot of new stuff that's always coming out, especially seizure meds. There's a lot of new seizure meds and what we call monoclonal antibodies. So I don't know if you've watched TV and seen psoriasis commercials, or almost any condition out there, there is something called a monoclonal antibody, which is an injectable medicine that binds to antibodies that treats certain ailments, and they all have their own side effects. So I think it's kind of cool to be aware of all these things. Anybody ever seen a device or know what that is? Pretty wild, huh? So this is called an LVAD, a left ventricular assist device. So this is somebody that's maybe had a major heart attack, or somebody that has a very poor functioning heart with no squeeze. And this is a mechanical device that inserts to the heart and has a pump system that's attached to a battery that pumps the heart for them while they're waiting on getting a heart transplant. So that's something pretty wild, and I have to be aware of what that is and the complications that come with that. We have a very aging population in this country, so more and more Americans are getting over the age of 60, and with that come a lot more health complications that I have to be aware of and how to treat. And then, has anyone ever heard of this device? So this is a vagus nerve stimulator. So people that have really difficult seizures to control can have a deep brain stimulator placed inside their brain that's attached to a little device that they can wave a magnet wand over, which stimulates. Yeah.
I just heard of this today.
I'll be dang.
Yeah, we're talking about cranial nerves.
Yep.
And a student was asking because she has epilepsy, and she was talking about this. She said, "Why do they choose the vagus nerve?" I didn't have an answer. I said, I'm going to give you the high school teacher best answer. I said, I think it has something to do with the fact that it's the most accessible because it's the only one that really travels down into the thorax.
Mm-hmm.
You know, where the other ones like to hang out up in the brain. So
Yep.
how does that work? What is it?
So the vagus nerve is involved in a lot of stuff, from digestion to heart rate to kind of sleep and wake. And so this nerve itself gets overactive during a seizure for most types of seizures. And so for people that are on like 5 different medicines that have very poor seizure control, they don't have any quality of life. And so they're always seizing, which can cause further brain damage. So this device it's implanted on the vagus nerve at a couple of points, and when there's a seizure coming on, it perceives it and it sends in a signal to dampen that nerve from being overactive, which can abort most seizure types. I think there's certain types of seizures that it treats, but it can help suppress them. And there's some that do them automatically, and others, if people have something called an aura where they feel a seizure come on, they can wave a magnet that activates. It's kind of like a pacemaker in a way. It's crazy. First time I saw one of these was when I was what we call moonlighting, working in a small ER in the middle of Ohio, and somebody had just had a seizure, and they were on like 3 meds I had never heard of, and had one of these things I had never heard of that had just gotten it placed at Ohio State University, which is like a big research medical school. So emergency medicine has ER docs that work in the ER doing shifts all over the country. And then there's fellowships, which are additional training pathways people can take to work outside of the ER for additional kind of things. So if you find that you like emergency medicine, but you like something extra, you can do extra things on the side. So I didn't do a fellowship. Essentially, my residency was an extra year. That's just how it was made. It was a 4-year program. So my extra year that I was there, I spent more time learning about EMS because it was something that I knew I was planning on doing coming home. So I'm a director of North Scott County Ambulance District, which is just south of Cape. And they cover an area, and they have a lot of runs at St. Francis and Southeast Hospital. So I wanted to learn how to do that. So I focused a lot of time outside of the ER. How do I help run an emergency medical service and write up protocols and how to treat and manage care? There's toxicology, which deals with poisons. So people that have ingestions of medications or get bit by a snake or a weird spider or something like that. These doctors focus on how to treat these and what antidotes are available for treatment of those. There's flight medicine, so docs that like flying in helicopters or fixed airplanes, they can treat patients in the sky and stabilize them in the air. There's hyperbaric medicine, which I don't know if you've ever heard of those, like those big sealed pressure containers that have high doses of oxygen. We see a lot of those for people that have really bad wounds that don't heal very well, that they go through multiple weeks of therapy to get treatments for wounds. Oop. And then there's critical care. So if you like working in the ER and you like working in the ICU as well, you can do additional year of training and be an ICU doc as well if you like being extra crazy. I got a buddy from residency that's doing that at Iowa State, and they do just crazy stuff up there, even beyond what you can imagine. Palliative care, that's a field of medicine that is involved with people that have chronic illnesses that don't have a cure, heart failure, COPD that have an expected decline. So these people can help treat chronic illnesses and improve quality of life with those. So these are just some additional facets from emergency medicine you can do outside of that. I think the biggest thing to consider whenever you guys are at this table is what path you want to take and how you get there. So I think the biggest thing for you guys now is to figure out what your interests are. I think they have different aptitude tests that you can do to kind of get an idea of what your personality's like and what you might be interested in. But I would start thinking from that approach. What do I see myself doing in 5 years? What do I see myself doing in 10 years? And how do I get there? And think long-term for a career. Is this something that right now I'm fine working 80 hours a week, but 10 years from now, am I going to be wanting to work 80 hours a week, or do I want to scale back? So try to think long-term about what your job may be and how you plan on getting there. From my perspective, from medicine, I wanted to volunteer and kind of get some exposure to get some ideas of what I wanted to do. So there's Big Brothers, Big Sisters, there's local food banks, and then I think the best thing if you want to go into ER is I think shadowing's a big thing, volunteering's a big thing. I would work customer service. So go work at IHOP, go work at Applebee's, and serve and wait tables, and you'll get an idea if you're fit for ER or not. Because you're dealing with people, you're dealing with multiple people, multiple personalities. You have to have a decent pace. You have to be calm. You have to be collected. You have to deal with the people that are angry, that are happy, and have to coordinate all of those emotions all at the same time. So I've heard of a lot of people that got into ER because they had experience working as a customer service patient or person working with the public. So kind of going with that intersection of life, begin with the end in mind. So I've met people that before they started any kind of training or volunteering, they wanted to do like a very specific pediatric cardiothoracic surgery. Pretty crazy. So some people have had experience doing those kind of things and know that they literally want to do that. They've been in the OR, they've seen clinics and seen what this means. Some people, it sounds nice. So I would recommend if you have a specific interest, go and do it. Try to get shadowing exposure. Try to volunteer in that environment to see if it's something that you really like, because then you can really invest your time and resources into getting down that path. This is kind of the path of getting through medical training. So after high school, when you guys graduate, you'll plan on going to undergrad school. I went to SEMO in Cape and did my 4 years there. So you'll do the pre-med part. You then have to do, on this little block right at the end of undergraduate, the MCAT. Has anyone ever heard of that test? It's kind of like the medical school entry exam. It's something that you have to take, kind of like the ACT, to get into medical school. And I think most schools require that. And then in medical school, you go through the basic sciences kind of again. You'll do that in undergrad, but you do it more so in medical school. So these are some of the basic subjects that you'll go along with. And then you start learning about disease processes. So usually that starts coming into second year of medical school, where you learn the basic medicine or the basic sciences, and then you start incorporating what does that mean for this disease? How do I learn more about that? And then these are the different exams that you have to take in medical school. So there's two different types. If you go to DO school or you go to MD school, there's two exams. So USMLE is for MD schools, but you can also do that if you go to DO. That's not something you need to worry about right now. You do step one. Once you pass that, you go into your third and fourth year of medical school. Those are the clinical rotations. You spend 2 years going through different specialties: cardiology, general surgery, family medicine, internal medicine, emergency medicine, yada, yada, yada. And you go through those. And usually by fourth year, you're trying to do more of the specialties that you think that you're wanting to go into to try to match into a residency. And at the end of that, you're finishing your second exam, which is your USMLE. These are all 4-hour exams, really fun. Then you start your first year of residency. So that's usually what we call your internship year. Sometimes for certain specialties, you may have to do some general rotations, kind of like what you did in medical school, whereas if you go into emergency medicine, surgery, you'll do more kind of surgical rotations. So you'll do that, you take another exam, and then you go through more of residency, you graduate residency. There's different years based on what specialty. If you're doing family medicine, a lot of times those are 3 years after medical school. So you have high school, 4 years of medical school. If you're doing family medicine, 3 years. If you're doing emergency medicine, there's 3-year and 4-year programs. For most surgery residencies, so if you've ever heard of a surgeon that takes out gallbladders, appendix, those kind of things, you're looking at 5 years after medical school. And that's if you're not wanting to do an additional focus like vascular surgery, where you go in and repair blood vessels from different types of diseases. There's dermatology, all kinds of specialties. So once you're done with that, some specialties go into fellowship. Some of those are 1 to 3 years, depending on what those are. And then after completion of that, you do a board certifying exam. That's for the specific specialty that you go into. That's really in depth. I think the biggest thing is just knowing that there's a lot of steps to the whole process and that there's little components to get to the end. So I just completed this part and got board certified in my specialty of ER. So now I'm a board certified ER doctor.
Do you have to be board certified before you can
No. So the way that board certifying exams work is they're spaced out. Ever since COVID, most of them are virtual. Back in the day, you would have to travel to like 2 locations in the country that would only have the tests like twice a year. So back in the day, you would either go to Chicago, which was kind of the big hub for a lot of different testing centers, and you'd go into an hotel. They'd have a whole floor blocked out, and you would rotate from room to room doing what we call oral boards, where you stand in front of an examiner and you go through different case scenarios. But now they do it virtually for most of these exams. A lot of different specialties do written exams where you just have to do multiple choice answers, and it's usually a 3 to 5 hour exam, and that's your board certification. Others, like ER and surgical specialties, usually have a written and an oral portion because there's procedures involved, and they want to make sure that people have the, aptitude of being able to do these things and proficient rather than just having Joe Schmo do a multiple choice exam and go out into practice. So a lot of times there's a lot of steps to each of these. So I went to SEMO. I did 4 years there. While in SEMO, I worked as a retractor holder at the ER or in the OR at Southeast. So I worked in surgery, got to get supplies and stuff ready for cases and operate the laparoscopes, which are those cameras that they use for certain abdominal procedures. So I learned real quick that I liked surgery, but I didn't like it enough that I wanted to do it as a career. So I knew that I liked procedures, but knew that that wasn't something I wanted to do long term. So I worked there for 1.5 years and got to know kind of the basics of a lot of stuff. And from there, I went to medical school. So I trained at ATSU in Kirksville, Missouri. Me and my wife at the time moved up there. It's a 5-hour drive north of St. Louis, I think it's about 45 minutes or an hour away from Columbia, Missouri. I lived there for 2 years, did all of my initial kind of basic science kind of stuff and lectures. And then we moved to Ohio in Columbus. Has anyone ever been to Ohio? Oh yeah? Where have you been? Columbus. Oh, nice. Awesome. So I trained in Columbus. There's a couple of different health systems in Columbus. It's actually a big metro area. It's like 700,000 people, but it doesn't feel like it when you're there. But I trained in Ohio Health, which is a health system there, kind of like Mercy is here in Missouri, but it's a big health system that has a lot of different hospitals. And this is my program. I think there was about 36 of us. There's some of my instructors and classmates. I'm up here. Right up here. But this is where I trained. This is a 4-year program. I think this was taken my last year of training. And I chose a 4-year program because I knew I wanted to learn all I could, knowing that medicine's getting more complex, but I also wanted the safety net of being able to work outside of my teaching institution as a resident and doing something called moonlighting. So I worked at a couple of different hospitals outside of my base site on my own before coming back here because I knew moving back to a smaller community compared to a metro area, I wanted as much exposure to doing procedures and things to make me confident and comfortable with my job. But everyone's got different, I would have been just fine with a 3-year program. I would have been just fine with a 4-year program. It's all about where you want to go, how you end up getting to what point you want to get. So this was the base hospital I was at. This is Doctors Hospital. It was a community hospital that had a lot of underserved people that had no follow-up, a lot of times uninsured, a lot of times a lot of complex health diseases that were poorly managed. So I got a lot of experience managing things that like heart failure or prescription drug use, IV drug use, alcohol abuse, things like that you may not see at other hospitals. So that was one experience that I had. This was Riverside Methodist Hospital. This was a big hospital that, I think they had probably 600 beds plus. But this was a major neuroscience place. So people that have strokes, brain bleeds, amongst other medical things would come here from all over the state to get their care. So people that have big strokes that are due to a big clot in their brain that's blocking blood flow would come to this place to have a clot retrieval procedure to suck out a clot to potentially stop further brain death and help improve the stroke that they had. And then this was a place downtown Columbus that I trained called Grant Medical Center. These are all part of the same like Ohio Health system. So I just kind of skipped around based on rotation that I was at to get different experiences. This is a trauma hospital. So this is essentially the #1 trauma hospital in the state of Ohio. So if you have the president, you have some bigwig or somebody that gets hurt anywhere in Ohio, they're probably going to go to this hospital as a trauma, which is pretty cool. So you get to see a lot of crazy stuff and injuries there. And then this is one of the bigger children's hospitals in the country. This is Nationwide Children's Hospital. This was in downtown Columbus. We did pediatric ICU rotations as well as working in the ER there. So seeing kids from all stages of life, all complexities of illness was really helpful to get my entire scope of understanding of taking care of kids outside of just working in a small community ER. So this is my family that we've had along the way. We started off with my little dog Ariel. She's a little black lab that we got right when we moved to Ohio. I think she's probably 8 or 9 years old. We got her from Humane Society in Southern Ohio. And then I've had 3 kids along the way. I had Owen right at the end of, I think it was my 3rd year of medical school. And then I had Judah at the start of my residency. And then I had Ezra this past June, so almost 6 months since being out of residency. So that's another thing to consider is what your job means is what is your work-life balance going to mean? So think about 10 years from now. Are you wanting to do something? Are you wanting to have kids? Do you want to travel? How does that job that you're wanting to do work into that? So that's something to really consider too. And then lastly, if you guys have any questions, like personal questions on how to get through the process, like anything specific to your scenario, feel free to email me at the top one. If you have any questions on how to get involved, like getting exposure, like volunteer opportunities, or even working in different parts of the hospital to see what you may like or not like, feel free to email me at the second one. And there's a lot of cool positions. So right in the ER right now, there's quite a few high school and college students that work as unit techs. So they work in the ER, they help to get EKGs, they help to get blood samples, they help to do some of the basic duties of cleaning up beds, cleaning up stuff, stocking stuff in the ER, and transport. So it really gets you a hands-on feel of what working with the public's like and what working with my field of medicine is like as well. So there's a lot of other positions I think available in the hospital as well, including the OR if you guys have any interest in surgery. So you can go, I think, to this. That should be a way if you're ever having interest. And you can look at St. Francis too, but Mercy specifically, you can go to that website. If you're interested in getting like a part-time gig to where you can make a little money and get some experience, I'd recommend that. Oh, yeah, please. So that's all I got. If you guys got any questions, I'm an open book. Mm-hmm. So 12 years total post high school of training. That's a great question. I think you got 2 schools of thought on that. Private schools more expensive, out-of-state schools more expensive. So when it comes to training and college and all of that, the first thing I would recommend is see what scholarships are available. Those are way underutilized, way under applied for. So if you get into college, start looking at like scholarship opportunities for anything you could think possible. They have them online. They usually have endowment funds that are part of college programs. It doesn't matter what you decide to go into. They got something for anything. So I would look into that. So like when I was in medical school, my tuition was about $50,000 a year. So that adds up quick. I think I came out with about $200,000 in debt, which is crazy to think about. I got people with $500,000 that I went to school with that weren't so smart with their money. So now I'm fortunate that I have some tuition reimbursement with my job to where I pay a certain amount and I get paid back a certain amount after each year, and that's going to work to pay off my debt in about 3 more years. So in-state school tends to be a little bit cheaper if you go to one of those. So I think SLU, Kansas City, like UMKC, Columbia, there may be a couple others medical school wise, tend to be a bit on the cheaper side, maybe about $15,000 to $20,000 a year cheaper. So those definitely take that into mind when you're looking at places to go, not only location but cost, because you don't want to be stuck with a bunch of debt that you can't pay off. And a lot of times the name isn't as important anymore as it was 30 years ago. Yeah.
How long, so like you, as an ER doctor, do you have like a specialty of like cardio or nurse or surgery or something like that? Or like how often do you have cases that come in and you're like, this is above what I know, so I need to get someone else?
So a lot of ER docs, and especially as a whole, we would clarify ourselves as masters of resuscitation. So that means people that come in sick, they're in what we call septic shock from a really bad kidney stone that's infected, that their blood pressure's low, they're altered. We're really good about getting people to a steady state of their health and getting a lot of the front-loaded care started to where the urologist that goes in and puts a stent in can get the downstream processes under control. Or we have patients that are really good at intubating people, so airway protection. Like I just had a person the other day that had end-stage COPD, which damages the lungs and affects the ability for the lungs to spring closed and open. And these people come in confused and in severe respiratory distress. So sometimes we have to place them on a mask that's like CPAP, like BiPAP, or intubate them and manage the ventilator and the sedation and all that comes with it. But we really have to know a lot about everything. I've had really big facial abscesses that I have to drain and close. I'll have leg fractures that I have to reduce, or shoulder dislocations that I have to put in. So we do a lot of things that are parts of different specialties, but a lot of times do the initial stuff that maybe even some surgeons aren't as comfortable with. I have a lot of bone docs that aren't as comfortable putting in a shoulder that's dislocated because they just don't do it. We usually do it most of the time. So there's a lot of different things that we do really well at, but maybe like the higher scope things, like maybe an endocrinologist, we may not be really good at fine-tuning one diabetic medication that gets them in perfect control long term. We get people stabilized, get a condition controlled so that people down the road can do fine-tuning stuff.
So you just make sure that you just try to get them to a point where they're stable so people down the line.
Mm-hmm. Yep. Exactly. Keep going, man. Fire it up. All the questions you got. I'm here literally to help you guys. If you have any questions, that's what I'm here for.
If you wanted to go into like EMS, like you said, or like EMT, stuff like that, how similar is like the amount of like how much of the emergency medical school do you have to go down to get into that?
You talking about for like a paramedic?
Yeah, paramedic, EMT stuff.
I will say, so the training difference is significantly different. We have charts that show, I guess, like a physician versus PA versus NP versus like different like portions of healthcare and how much training and how much, I guess how much training is involved to get to each point. And there's a significant difference. So by the time that I got towards the end of my training, I'm looking at probably about 10,000 hours worth of experience. That's a lot. That's usually, if you've ever heard, there's some different theories on the 10,000 hour rule of mastering something. So you ever heard of that? Like with people that play a violin, you're not going to be really good or a master of something until you've spent 10,000 hours doing it. I'm not going to be able to go into an operating room and open up somebody's chest and do an open heart surgery. That's not what I trained on. I can do different procedures that are kind of around that, but that's not my focus of specialty. So paramedics, I can't give you the details on that, but there's typically at least usually about 2 years of training. You have to go through an EMT course, and then you have to go through an EMT basic and then advanced and then get certified in that. And then you have to get, I think, about 2,000 hours worth of run time and then go into paramedic school, which is, I think, about 18 months a lot of times. So you're probably looking at a year to 3 years after high school of going through all of those steps to becoming a paramedic. So, I mean, it's hard to encapsulate, I guess, an entire job in like 30, 45 minutes, but I love what I do. I think it's really fun. It's not without its negatives, just like every other field. You're dealing with people that are at their most stressed, they're most worried, and a lot of times most upset. We get a lot of people that use drugs that come in combative, altered, angry, and punching. That's not in the job role or job title that you expect, and you have to learn how to deal with those emotions. Like within the past week, I've had to tell at least 3 or 4 people that they have a terminal cancer that they're unlikely to survive, and having to deal with unpacking those and coming home and getting back to normal life. It's a delicate balance, and I'll be the first to admit, my wife will be the first to admit, it's hard to transition. If I'm working 4 days straight and I see upwards of 80 people, all of with different complaints, and then I come home, it's sometimes hard to unpack that and unwind and to sit down. There's a lot of correlations with medicine in like battlefield, like working in the military, seeing having PTSD to events. I mean, a lot of things that we deal with are emotions that most normal people on a day-to-day don't have to deal with or see maybe ever in a lifetime. So there's a lot of responsibility that comes with my line of work that I have to respect and appreciate that, it's not all people see or do and have to experience. Anybody have anything else that they're interested in or questions? Biggest thing that I can recommend is just try to get volunteer experience and try to work in what you think you might be interested in. And so like physical therapy, work in a clinic setting and try to get shadowing in a hospital setting. They're 2 totally different ball games. My wife's an occupational therapist, and she went to Maryville University, and she started off working geriatrics in a nursing home. She found that she didn't like it, and when we moved to Ohio, had the opportunity of working at a children's hospital, and she's transitioned to doing pediatrics. She loves working with kids. She deals with sleep and sensory and feeding disorders in kids at an early age. So I think the biggest thing that I see most people regret when they're going through the process of healthcare is not knowing fully what they're getting into and not fully realizing that until they're on their way to completing it. Because medicine's really hard. There's a lot of other fields as well that are really hard, but I didn't go into medicine for the money. The money is nice, but it's not everything. And there's a lot of people that have been working 5 to 8 years sooner than I have that have been making, in a similar amount, probably a little bit less, the same, amount of money, but having that many more years out of school and training and all the sacrifices that come with that. Yeah. DO. They're pretty similar. It comes down to a lot of it is incorporating. Have you ever seen chiropractic medicine? We incorporate osteopathic manipulative medicine, so a lot different muscle energy, stretching, things like that into our healthcare and practice. So I know how to do a lot of different stretches, a lot of different functional kind of treatments for people, back pain, extremity pain, a lot of things from that end. And then also they really focus on holistic healthcare, so seeing people and their disease process from the whole. So if I have somebody like I was talking about earlier that was 80-year-old on 9 different medicines, fell and has all these problems, they're going to try to figure out, why is this happening? How do I fix the whole person in this scenario and try to make their health better as a whole? MDs and DOs do that similarly, but I think there's more of a focus on that in whole person healthcare and the focus on all these variables into one person to make, their circumstances unique. Same training, same length of training, very similar in nature. You learn the same medicine, still physicians at the end of the day, but different ways of getting there. Yeah, another thing too is if you guys are ever interested in shadowing the ER, I'd be more than happy to have you guys follow me around on a shift and try to get you involved. That way you can see, nope, don't like it, or yeah, I like it.
Thank you so much.
Oh, yeah. Oh, heck yeah.
One of the best ones we've had.
So, I appreciate the effort you put in your slideshow.
Oh, appreciate it.
House was good.
I appreciate your